You're listening to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. We'll be joined by cancer experts to discuss blood cancer diagnosis, treatment, survivorship, side effects management, and the importance of clinical trials. They will share their experience in treating patients and discuss strategies for optimal patient care. Let's get the conversation started.
Welcome to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. I am Dr. Ken Miller. I'm a medical oncologist, hematologist, and a volunteer for Blood Cancer United. And I want to thank all of you for joining us for this first episode as Blood Cancer United. And this is a good opportunity to say what an exciting change it is. Obviously, it's been under another name, LLS, for many, many years. But I love this new name, and I think probably better describe what our wonderful organization is about, which is caring for people with blood cancers and trying to find cures. Today, we'll be discussing pediatric acute leukemias, including current treatments, challenges, outcomes, and long-term effects on survivors. We'll also take a closer look at the Blood Cancer United Pediatric Acute Leukemia, PEDAL, Master Clinical Trial, and share key resources and strategies available to support patients, families, and healthcare professionals. We're delighted to be joined by three guests today. Ann Collins, who is the Blood Cancer United PEDAL project leader. Ann, introduce yourself if you would.
Sure. Thanks, Ken. I'm delighted to be here today. I am the global program lead for the PEDAL initiative. I come to Blood Cancer United after a longer career in biotech, largely in adult leukemias, and I have found a home in leading the PEDAL program globally. I can't wait to tell you more about the master trial and reveal some milestones that we've hit with that. And I'm delighted to be joined by Kelly and Sarah, who I get to work with closely on PEDAL.
Terrific. Another guest, Kelly Laschinger, who is director of the Blood Cancer United Clinical Trial Support Center. Kelly?
Yeah, thanks, Ken. I'm also so excited to be here today. I am the director of the Clinical Trial Support Center, or the CTSC, as we call it lovingly at Blood Cancer United. So I get to work with a team of 13 amazing nurse navigators. And I'll tell you a little bit more about what we do on the day-to-day, but I am a pediatric oncology nurse practitioner by training. I worked for about 20 years at Rainbow Babies and Children's Hospital in Cleveland, Ohio. Always in Peds Hemonc, doing many different things over the years, inpatient, outpatient, survivorship, but always in pediatric cancer. And I came over to Blood Cancer United about 7 years ago, and it has just been wonderful. We have so many wonderful resources for patients, families, and our providers, and I'm excited to tell you more about them.
That's great. And finally, Dr. Sarah Tajian, who's an associate professor of pediatrics at the University of Pennsylvania School of Medicine, chief of hematologic malignancies program at Children's Hospital of Philadelphia. Sarah, tell us a little bit about yourself.
Oh, thanks so much, Ken. So I'm Sarah Tajian, an academic pediatric oncologist in Philadelphia, and I am the clinical trials leader for the Blood Cancer United PEDAL initiative. And it's been a real pleasure to get to work with talented people, not just in the United States. In my normal life, I see patients about 25% of the time and exclusively focus my clinical practice on the care of children with leukemia and lymphoma and other blood cancers. And then I'm also a precision medicine leukemia-focused academic researcher in my laboratory at CHOP, as well as an experienced early phase clinical trialist. In addition to spending time in Philadelphia, I had the pleasure of spending a year abroad in the Netherlands at the Princess Maxima Center in Utrecht, and really had a wonderful perspective seeing how we work through the PEDAL initiative internationally. So it's a pleasure to be here with all of you today, and so great to work with Kelly and Ann in these efforts.
Let's start up, if you would, Sarah, with just an overview of pediatric acute leukemia. And I'd love your perspective, maybe the very broad 60,000-foot perspective on where we've been, but even where we need to go and where we should be going.
Sure. I think it's a remarkable achievement in pediatric oncology, Ken. 50 years ago, having a diagnosis of acute leukemia for a child was effectively a death sentence. And we now know through cooperative clinical trial iterations and making more success over the past 5 decades, we are now able to cure the majority of children now with newly diagnosed acute leukemias, particularly for children with ALL. We can cure more than 90% of those children with frontline therapies. But because this is the most common leukemia that we see in those who relapse, it still remains the leading cause of childhood cancer mortality. And so this is really an area where we need to do better in terms of better therapies, precision medicine therapeutics with small molecule inhibitors, and potentially immunotherapies. Children with AML, which is the second most common cause of acute leukemia in children, don't fare quite as well. We are fortunate to cure about 2/3 of those children with frontline therapy, but that treatment is incredibly intensive and often requires bone marrow transplantation for somewhere between a third and half of children. And that certainly causes a lot of both short and long-term toxicities that I think we'll touch on later during this conversation. And this is an area where we really need to do better for those children with relapsed AML. And this has been a major first focus for us within the PEDAL initiative to develop better precision medicine therapeutics and clinical trials that we hope can bring better opportunities for patients worldwide.
PEDAL is a global trial, but both in other parts of the world and even developing nations, talking about Africa and otherwise. What is the status of treatment and delivery of care for little children throughout the world?
Yeah, that's an excellent point. We certainly know we can cure a large percentage of children with less intensive chemotherapy. I think in the Western world, we are very privileged to have access to remarkable combinations of medications, some of which are extremely expensive. Nonetheless, we can still cure a percentage of children, even with maybe not gold standard medications, but things that are a little bit more affordable and a little bit more available. I think one of the things that is challenging certainly is in terms of genetic diagnostics. We are very privileged in first world countries to have very sophisticated genetic testing that really helps us to inform risk stratification and how we select regimens or medicines for patients. And these technologies are not widely available, particularly in developing countries. But nonetheless, I think a lot can be done with information at hand. And sometimes returning to the basics, we should not forget this is really important both in the diagnosis and the cure of our patients. And I cannot emphasize the importance of supportive care enough in terms of antibiotics and just being very pragmatic in how we support the nutrition and the pain management for our patients too.
Absolutely. Along those lines, what are the late and long-term effects on children who then become long-term cancer survivors?
So we certainly know that there are specific medications that cause short-term toxicities, and then there are some that also cause long-term toxicities. For patients with AML, for instance, we particularly worry about the total cumulative exposure to anthracycline chemotherapy drugs. These are very important, we know critically important for the cure of these patients, but also can be associated with both short and particularly long-term heart damage. So we want to cure these patients, but not at such appreciable cost that they can't go on to live normal and healthy lives. Many of the other medications that we use can cause problems with the bones or problems with the kidneys, and we really have to monitor patients during therapy to be sure that we are using appropriately aggressive therapies, but also not at such great cost that they cause toxicity that may outweigh the benefits. So both during therapy, but certainly in our survivorship programs, monitoring the total doses of therapies that children have received, including sometimes radiation and certainly bone marrow transplant that are associated with longer term toxicities is critically important. And I think Kelly may also be able to speak to that point.
So let me ask both of you, Kelly, Sarah, let me reflect on a part of adult medicine, oncology. But I remember DaVita did a long-term follow-up on the first patients treated for Hodgkin's disease, a lot of whom had radiation. But you looked at the curves, the incidence of sarcoma, the incidence of secondary cancers, second cancers, and it went up and up and up over the years to the point that it really reached about a third or more of the patients had significant toxicity. With today's treatment, or this generation of children who are becoming long-term survivors who are getting chemotherapy alone for, let's say, ALL, what are your expectations of the cumulative toxicities? Will they be as dramatic as what I'm describing, or hopefully not?
Yeah, things have gotten so much better, but I think some of these newer therapies too, we just don't know what we're looking for in survivorship clinics with some of the CAR T cell therapy and these newer types of agents. So that will be yet to come. But yes, I think things are so different from taking care of patients from 20 years ago and the survivorship list that we would print out about things that we need to follow up with. You know, the steroids have been decreased, which decreases tons of toxicity for kids that are being treated for ALL. We're doing better with giving the right kinds of steroids to older kids and younger kids and decreasing how many steroids we're giving over maintenance, which is years and years. And hopefully that will benefit these kids over time. I think the toxicity that we see that is still very difficult in clinic and then in the schools too is just sort of this chemo, brain fog, sort of processing speed, executive functioning, these things that we see, especially in kids with ALL, that are very difficult to monitor and very difficult in the school setting to get things like IEP and 504 plans and things like that. I really hope that over time, as we decrease these medications, get more towards precision medicine and away from some of these toxic chemotherapies, that we will improve those types of things too, which are not as objective and easy to follow as some of these things when we talk about the heart and the kidneys and the liver. That's sort of where I see as a nurse practitioner too, just going back in practice, trying to talk to the school, talk to families and work through some of that. That has been big for me to kind of keep an eye on too and help families try to work through.
Absolutely. Sarah?
Sure. I think with respect to childhood ALL therapy, one of the best advances we've made in the last decade has been a reduction in cranial radiation for patients. So children who were diagnosed with ALL in the 1980s, upon recognition of the CNS as a sanctuary site where a lot of our systemic chemotherapies didn't penetrate so well, we knew that radiation therapy could be very effective in treating that part of where leukemia can go. We've subsequently learned that intrathecal chemotherapy that we give through lumbar punctures can be just as effective as radiation, but potentially a lot less toxic. And I think in modern times, we're radiating fewer than 5% of children with ALL right now, which is huge. I think to touch on Kelly's points about neurocognitive deficits that are very real, but very hard to measure. And certainly risk of meningiomas, even though those are benign brain tumors, they're very problematic for patients and they happen 20 and 30 years later. So I think that's been one of the major advances in recent years. And then certainly with all of the emphasis on the successful intercalation of immunotherapy, particularly blinatumomab, this has really turned ALL therapy for not just children, but also adults on its head. And we are really interested in using such immunotherapies to increase cure rates, but also give us finally the ability to very aggressively decrease the intensity of toxic chemotherapy that we know are associated with short and long-term side effects. And to be honest, I think our adult colleagues in medical hematology have been a step ahead of us in recent years because of the toxicity that young and older adults have with conventional chemotherapy. They have been much better able, I think, to push the blinatumomab envelope. And so we as pediatric oncologists have learned a lot also from the adult trials in addition to our own pediatric trials about how this can be successfully done. And I hope that we will continue to pursue those goals, better risk stratification and de-intensification of chemotherapy to reduce some of those outcomes. Because we know that children are still at increased risk of obesity and a shorter lifespan after childhood ALL therapy compared to their siblings. And so we have to do better.
Let's talk now, because I think it's such credit to Blood Cancer United, to the pediatric oncologists, to the staff, et cetera, for creating the PEDAL trial. So, Anne, I wanted to ask you, what is the PEDAL trial? What's the vision behind it? And tell us more about it, if you would.
Sure, I'd be delighted to. And admittedly, I stand on the shoulders of Sarah and Todd Cooper and Gwen Nichols and Andy Kolb, who had this vision years ago and brought the crown jewel of PEDAL, which is the master trial, the screening trial, to launch in 2022. Today, I can say that over 500 children have been enrolled to the screening trial and are longitudinally followed and genomically sequenced. And that's extraordinary. I mean, I really can't point to another disease or registry in a rare disease setting that has such extraordinary depth and longitudinality of data. And that will pay dividends for years to come as we can benchmark for other trials, as we can use this data to inform better research going forward forward. But really, the principles are simple, that every child with AML and some subsets of ALL gets enrolled to the screening trial, single portal of entry to allow for the longitudinality of data, genomic sequencing for risk stratification, better diagnostic accuracy, and treatment allocation so we can tell the patient and family something very detailed about their leukemia, which informs a treatment choice. Sometimes that will be a PEDAL subtrial, which can be a targeted therapy or a not targeted therapy. And sometimes that's a PEDAL subtrial, but it's information we deliver to the family and the patient just the same. And people like Kelly and her team are able to steer them to appropriate clinical trials.
And, give some examples if you can. So a child's diagnosed at UPenn, for example, or at Hopkins, et cetera. What happens then?
Well, you mean in terms of accessing the PEDAL trial, and I'll start, and then Sarah, who actually does the work, may have something to say about it. But through COG, we have a vast network of investigators, both in the US and ex-US, who are investigators for both the screening trial and some of the treatment trials. So the enrollment to the trial is offered to the patient and to the family for the screening trial, both for a collection of data and for the genomic sequencing and learning more about treatment options. But Sarah, you may have a more day-to-day view on how that works.
Our screening trial, or the APAL 2020 SC study that Anne is referencing, has just really been a wealth of information. The diagnostic or relapse samples in this case are submitted for very comprehensive genetic characterization on a uniform platform. And what also has been very helpful, I think, to touch on immunotherapy again, is that we subject them to a comprehensive, very detailed immunophenotypic flow cytometry analysis that helps us to find regular antigens that might be of interest for conventional therapies such as gemtuzumab. But we have, through a partnership with Hematologics in Seattle, Washington, been able to look at really nouveau antigens that may be helpful for targeting with some of the more kind of phase 1 categories of immunotherapies that we hope to bring into the PEDAL pipeline in the future. So it really is, as Anne said, a wealth of information to characterize the exact molecular fingerprint of these children's leukemias and understanding what may be targetable on both the outside or the inside that may be amenable to some of the precision medicine subtrials, or to help investigators even outside of these trials have a better idea of a conventional chemotherapy that might be an option for their patient that perhaps they haven't thought about. And I think the liaison back with Kelly and her team to help them to understand what PEDAL trials are available, but what other studies might be out there that could be relevant for their child's specific leukemia has been incredibly helpful. But for the PEDAL subtrials, right now, we have 2 active therapeutic subtrials, one of which is fairly broadly relevant for children with relapsed AML, and it's studying an important drug in a randomized phase 3 way that we're really hoping to understand the potential benefit specifically for children. This is the BCL2 inhibitor venetoclax that we're giving in combination with a standard of care relapse salvage regimen. As we know, this is a drug that's FDA approved for adults with AML and used in a variety of indications, but we're really still gaining experience with this in the pediatric domain. So that is a great trial, and we're very fortunate that the APAL 2020D study is open fairly broadly throughout the US and Canada, as well as in Europe and even in Japan. So this provides a lot of options, I think, for patients with relapsed AML. And then our other therapeutic subtrial right now is studying a menin inhibitor called ziftomenib. This is being done in a non-randomized way, but we again have been very keen to hear the exciting data from adult trials in patients with relevant genetic subtypes of acute leukemias, both AML and ALL, and even a mixed phenotype acute leukemia, and trying to understand can ziftomenib targeting a critical menin complex also be very effective for children with relapsed acute leukemias who have that relevant genetic subtype. And these trials have accrued incredibly quickly. I think there's tremendous interest and need for our patients. So we've been really fortunate to have these open internationally for patients in need.
Ken, I'll add just a couple of things about these sub-trials, because I think they underscore 2 really important points. In the case of venetoclax, that it underscores this 9-year gap between a product being developed with pediatric understanding and dosing and after the adult indication. And Blood Cancer United is exactly the kind of group that would take that on. But we're not just sitting around waiting to get these adult drugs into kids. We have to do better. We have to close that gap. And if you look at the menin inhibitors, I think that's a real success story. And here we are with ziftomenib coming with a pediatric study on the heels of the adult work. And I think that speaks volumes to the success of the PEDAL infrastructure. We benefit from our longstanding relationships with pharma and the FDA. Sarah and her teams get involved early on in developing the PIP and the PSP, and we really have a hand in talking about clinical development program for pharma who lacks the incentive to do these trials. And then we bring in an infrastructure to say, we can actually operationalize this trial for you. I think that these two trials in particular, side by side, tell quite a story.
I'm so glad you brought it up because what a great story that is. I started hearing about menin inhibitors about a year or two ago at most, and how fantastic it is that it's already in a pediatric trial. I want to ask a more personal question. First, I'll share a story, but 26 years ago, my wife was diagnosed with AML. Fortunately, she's okay. And I actually have a lot of thanks to the now Blood Cancer United for support. When a family has a child just diagnosed, what a difficult time that is. What are some of the barriers that they might feel? What are the worries they feel about participating in a trial like this? And how do you explain them? How do you provide that information and hopefully reassurance? So I'll ask any of you.
So I saw the patients for many years too, but it is interesting, working here and getting phone calls from patients all across the country. When you work in one center, it's like you just learn about your center and what happens there. And when you work somewhere like Blood Cancer United, you're helping patients all across the country. I think in pediatric oncology, it's a little bit different than in adult oncology because of this children's oncology group. And really what I have found, pediatric oncologists, is a small group and they're close-knit. And so it seems very different to me now taking care of adult patients too, how absolutely wonderful it is to be a pediatric oncology nurse practitioner. It does feel like on the adult side, we don't have as much support maybe. But I think patients are at first nervous about hearing a clinical trial. There's always sort of that nervousness about joining a study and you're thinking about your child too. But I think, again, providers are so wonderful at explaining that we have this wonderful network, this COG, this children's oncology group, that no matter where your child would be treated across the country, you're pretty much going to get the same treatment. I think that makes parents feel much more comfortable. For our patients where there is a COG study open, it's open at many of the centers across the country. And Sarah can talk a little bit more about this, but I do think it's nice for parents to kind of hear that we've made these strides and we are treating patients all across the country with a very similar therapy. Sarah, do you want to add to that?
I echo all of those thoughts, Kelly, and agree with you in the frontline setting. I think when we get into relapse domains, that's where I think it becomes extra stressful for patients and families. I think that the pediatric oncology community is really special and very closely knit. And I think we're very happy to talk to colleagues, to ask for advice, and to help a child get to another center if there is potentially an option in an earlier phase 1 or phase 2 trial that might not be available locally. This is not always possible for patients and families. There's other children, people have jobs, other kids need to go to school. And I think that that's where we've been so grateful to Blood Cancer United for their psychosocial support of patients and families. Ken, you may know this from personal experience as well. It really takes a village, and even for very motivated patients and families to get to another center, it's incredibly expensive. It's incredibly stressful. And I think the community really rallies around these kids and their families to help them to get to the place that they want and need to be. So I'm very grateful for those resources and that support and just that kindness.
I wanted to share just a recent outreach that we had from a healthcare provider. So they had a couple of kids at their center enroll into the screening trial, but at this center, they did not have either of the sub-trials open. So he had reached out using askpedal@lls.org to find out where the closest locations would be for the child to travel if they were eligible for one of the sub-trials. So that's just an example of sort of what our team can do in the CTSC is to help patients find the next closest site. If it is going to be a PEDAL sub-trial, we can certainly give providers that information. And then, of course, do the navigation to help overcome any barriers should they need to travel far. All of the things that Sarah brought up earlier, sometimes there's insurance constraints when you're traveling between states and things like that. So between the CTSC and the RC, and even our Office of Public Policy sometimes helps us with cases like this, we will really try to help patients get where they need to be and overcome some of those barriers. But if providers have any questions about, maybe they do have that screening trial open at more than 200 centers across the country, but only a handful of the centers do have the sub-trials open, their earlier trials. The ziftomenib trial is an earlier phase trial, so not open at all of the COG centers. The pediatric nurse navigators help with any navigation there to make sure the kids can get to where they need to be.
Absolutely. Those are the days that I think patients, families remember. They remember the kindness and how much we as a medical community really reach out as people in sort of their worst days. And I wanted to find out a little bit more about the infrastructure, the consolidation of clinical trial data, dealing with multiple international institutions, having a unified data set. What can you tell us about that?
We're incredibly excited and proud of the data set that we're building. Part of the PEDAL initiative includes an Interact data set at the University of Chicago, Data for the Common Good, which now has close to 5,000 global records of patients with relapsed leukemia. And we're just starting to query that data set, but fascinating for me to think about global treatment pattern information, to include global social determinants of health, to include top line data on how patients are treated and following their course globally. And then the 2020 SC, our screening trial, feeds into that as well. So like I said before, really unprecedented for a rare disease to begin a data set that can be accessed by global investigators for further investigation. And I look forward to the fruits of that data set bearing out over the next few years.
Where are some of your clinical sites? I think the listeners and I would love to hear.
Oh, we're throughout the United States at over 200 COG sites. We're in Australia, New Zealand, throughout Europe. We don't have a site there, but we've had data contributed to our data set by Egypt. So a truly global initiative in terms of contributing data for scientific query and then clinical trial opportunities. So we take it very seriously that this is a rare disease. So we need global cooperation, and all of our trials end up being offered internationally.
Let me ask a related question. Are there other sub-trials sort of in process of being developed? And what do you anticipate in terms of where this will go?
The short answer is yes. There seems to be always discussion going on. We're either contacted by pharma collaborators who want to talk about the development of their drug for a pediatric indication. And in the process of Sarah and her team advising them, sometimes we figure out that Blood Cancer United and PEDAL is the right place to run that trial. Pharma may decide to run it themselves, or they may approach a cooperative group. So we really work with them every step of the way. And it really is along the lines of comprehensive advice about the pediatric development plan and where's the right place and how do you develop that trial. The vision that there will be a PEDAL master trial, screening trial that will continue to provide the infrastructure, that Blood Cancer United and PEDAL will continue to be a place where some of those trials can get initiated. Besides waiting for pharma to approach us, we're also in constant communication with our key opinion leaders and investigators who will have interest in a certain class of drug. We're pursuing a class of drug right now that seems to be not engaged to the extent of our liking in pediatric leukemia. So we contact all the sponsors and the manufacturers who have that class of drugs and educate them the plausible pathway in pediatric leukemia and invite them in for a conversation.
Wow, terrific. So I wanted to ask also about clinical resources for patients and their families and healthcare providers. Kelly, what can you tell us about that?
Our clinical trial support center is a team of 13 nurse navigators in total, but there are 4 of us that are pediatric oncology nurse practitioners. We've worked for decades in PED-CMONC prior to joining Blood Cancer United, and we are here. We help patients, we help families, caregivers, and providers. Our main role is really to help providers and families identify potential clinical trials and overcome barriers that they may face to enrollment. And we do this through talking with patients, caregivers, or providers to learn what they're looking for in a clinical trial or a treatment. And we do this over the phone or we do this through email. We have a referral form on our website that can be filled out so that the nurses have some details and can do some pre-work before they're making their initial assessment calls. And then if families or providers don't want to fill out this form, because I know sometimes that can just take some extra time, that's totally fine too. They can always email us. There's an email box that's manned by myself and the other pediatric nurse practitioners, which is askpetal@lls.org. And you can also get to our CTSC at ctsc@lls.org. And providers or patients can also always call our Information Resource Center. It's 1-800-955-4572. No matter how the provider or the patient gets connected with our team, there's a primary nurse that gets assigned and we'll reach out to that patient or that provider quickly. We typically do this within hours, but definitely within one workday. And we do practice primary nursing because we really want to get to know our patients, just like we did when we worked in the hospital. So once a nurse is assigned to that patient, the nurse will give that patient or provider her direct email and phone number, so they can then communicate directly with their nurse navigator as often as they need to. All of our pediatric patients will be assigned to either myself, Melissa, Sloan, or Susanna. We're the 4 peds nurses on our team. And then once they're connected with one of us, we'll really meet you where you're at. So if you're looking for clinical trial options for your patient, we will make sure to get the information we need from you to comb through eligibility criteria and then send you a clinical trial search report, typically within 1 to 2 days. We will provide you with the most up-to-date information that we have about the trials that we find. We do an enormous amount of outreach to clinical trial sites, to sponsors, to really try to provide the most up-to-date slot information we have and eligibility information that we can. We're here to be an extension of the healthcare team by working in tandem with providers to get that most up-to-date trial information. The pediatric nurse navigators are often reaching out to pediatric leukemia experts like Sarah. We reach out to her often, and she's so wonderful, gets back to us very quickly. But they really help us when we need further information about a trial at their center. We have a clinical trial navigation hub that we use to keep all of our trial outreach at our fingertips. And as we are gathering information about any specific trial, we add it into our hub. So the next nurse that looks at that trial can see it, and this really streamlines our process. So although we're searching for clinical trials, and that's really a big piece of our job, we're also really here to educate the families about their diagnosis, about their treatment options. We can help with second opinions, and we're here to listen, of course. Every patient we help has different needs, so we'll use all of our resources to really help in any way we can. We're not giving medical advice, but are just really here to try to offer education and information from trusted resources, and then patients and families can then take that information back to their providers so they can have meaningful discussions with them about what their options might be. And then outside of nursing, working directly with a nurse navigator, there's numerous educational and support resources that we have here at Blood Cancer United. Hopefully, many of the people that are listening are familiar with our educational booklets. We have disease booklets that are specific to pediatric ALL and AML, and then, of course, tons of webinars and podcasts, and even CME and CE offerings for our healthcare providers that are all free. We have a lot of newer resources for our pediatric patients, too. We have a really adorable book series that's about a little girl that's going through leukemia treatment, a back-to-school guide. We talked a little bit about school earlier in the podcast. We have survivorship workbooks that are awesome and can help patients kind of keep track of those cumulative doses. The providers can write the cumulative doses down there so the patients have something that they can keep with them as they age and move on to college and afterwards, so they have a nice record of, what their next primary care physician can be looking at for them. So we have resources really for young kids, for teenagers, for young adults, because all those different 3 age groups there, the way that you want to present information is different and they learn differently. So we do have resources for all 3 subsets of our pediatric patients. And of course, these are all free. So you can order them for your clinic, as many as you want, as many as you will use, and they'll be sent directly to your clinic to be able to give to your patients. And then I also want to mention just really quick is our scholarship for pediatric blood cancer survivors, because it's actually open right now. So the scholarship is open through September 30th. So for all of you that see kiddos who are looking to go to college, please have them apply. It's an awesome reward. They can get up to $7,500 for this scholarship. I used to work in our survivorship clinic, and I was always trying to keep a list of all the scholarships available. And this one would definitely be at the top of the list. The amount is very generous. So definitely encourage that. And then, of course, our financial assistance programs too. So all of these things, you can contact one of the nurse navigators or call the IRC.
Awesome.
And easily get access.
So I have to say, as you're describing this, especially, talking about the contact with the nurses and some of the initial contact, I'm picturing for a parent or for a patient or for a family, that sense of, meaning a sense of relief when you've connected with someone like one of you or your group. So I want to thank you, which I hope you hear a lot of. And I want to ask you the same thing. If providers, and Sarah as well, if providers want to learn more about the PEDAL trial, how should they do that?
So you can learn more about PEDAL on the Dare to Dream initiative page of our newly branded Blood Cancer United website, or always email me directly, ann.collins@lls.org, until we switch over to @bloodcancerunited.org.
And Sarah, I have a final question for you. We started out talking about the past and the future and how much progress you referred to 50 years ago. So let's even go 50 years from now. I think you may be retiring by then. But what would be your hopes, your wishes, your expectations about what the discussion would be like then?
Yeah, I would say if I could dare to dream about the future, Ken, I think what we really hope is to cure more children with fewer toxic side effects. And, the more we can push the needle or push the envelope with access to precision medicine therapies, immunotherapies, learning how to use the tools in our toolbox right now in a smarter and less toxic way for children, I think is going to be really important. And we all know that drugs may be less successful in a multiply relapse setting, but if we can move them forward to children with the appropriate types of leukemias in the frontline setting, we probably can reduce those risks of relapse. And I think we would all love to be able to have access to the most precise and tailored therapies for these children. And I hope we can take the blunt tools of our conventional chemotherapies a little bit out of our toolbox in the future as we have better access to these precision ones.
Absolutely. So I want to thank all of you for listening to this terrific episode. And I want to thank again our three guests who are really making all this progress possible. Ann Collins, Kelly Lassinger, and Sarah Tajian. And thanks for being with us.
Thanks so much, Ken. This was great.
Thank you.
Yeah, thank you.
For a listing of all of our healthcare professional continuing education activities, podcasts, and healthcare professional resources, please visit bloodcancerunited.org/CE. For any questions or to refer a patient to Blood Cancer United, please contact our Information Resource Center by calling 800-955-4572. Information specialists provide personalized one-on-one support to help patients learn about their disease, treatment, financial, and support resources that are available in English and Spanish. Blood Cancer United also provides other resources for patients, survivors, and their families, including Stars Will Twinkle, The Sun Will Shine, a 3-book series and movie for children with blood cancer. And to learn more, please visit bloodcancerunited.org/support. I encourage you to sign up to receive notification of future podcast episodes by subscribing at treatingbloodcancers.org. And if you have suggestions for future episodes, please click the feedback button on this episode page, and we look forward to you joining us on future episodes.
Thanks for listening to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. We can be found on iTunes and other podcatchers. You can subscribe at www.treatingbloodcancers.org and provide your suggestions for future topics. Visit our archive section on our website for other great podcasts. Be sure to rate and review us on iTunes. Keep up with Blood Cancer United by following us on social media and access our healthcare professional continuing education activities by visiting bloodcancerunited.org/CE. Let's keep the conversation going. Until next time.